Hey, everybody. Thanks for joining us today for the fifth part in our Data-Driven Analytics webinar series. Today, we're going to be talking about customized key performance indicators, and I'm happy to be joined today by our CEO, Russell Hendrickson. Thanks for joining us today, Russell.
Good day, everyone, and thanks so much for joining us. Excellent. And for those of you who aren't familiar with PDS, we specialize in healthcare data analytics, and we like to focus in some of our different content areas. We call them focused business insights. And so if you're not familiar with PDS, we certainly invite you to get to know us. But for today's webinar, we really thought we would kind of shake out of some of the things that we do for our clients. What are some of those customized metrics that come out of all the different areas that we work in? And that's what we're going to be talking about today. And in preparation for the webinar, Scott, I was up late last night and looking for kind of a quote that would best summarize what we're going to do today. I came up with this: measure twice, cut once. This old adage is key in KPI management: measure the right things and measure them accurately. And of course, the famous, philosopher anonymous here is who I'm quoting. So
yeah, we tend to use that one a lot. But yeah, I think it's important that we do talk about the customization of KPIs, because the fact of the matter is that this whole one-size-fits-all philosophy in healthcare really isn't true when it comes to KPIs. Every single practice is a little bit different. They have different strengths, they have different challenges, they have different priorities, initiatives that they're working on, that they're trying to track more closely than others. And the fact of the matter is, what may be important to your practice and what you're tracking may be a little bit different than what's in any of the other practices in your market or even across the country. And so it's really important to be able to get to exactly what you need, because those KPIs are important. I know that, like you, Russ, I was searching out quotes while I was waiting in the airport to go on my fun, sunny vacation, and found that, KPIs are like a compass. And what we're trying to do is utilize these KPIs to guide us where we're going and meet our definition of organizational success.
Excellent. Great quote you found there, Scott. So in the past, our series, this is part 5 of our data-driven webinar series, and we talk quite a bit about what does it mean to be data-driven, right? Using data continuously, applying data to uncover opportunities, and then, using insights from data to improve performance. And that's really what we're trying to do, being a data-driven organization. And so then, we talk about what are traits of data-driven organizations, and that would include having on-demand access for users, being able to explore data from, gains in performance, regularly talking about data and bringing data to meetings. It's one thing to say, hey, we have a problem. It's another thing to say, hey, the data shows that we have a problem with billing or registration or check-in. Right. So organizations that are data-driven tend to have a commitment to analytics. They see analytics as an investment, and it really becomes part of their culture. I was going to say, I found another quote I wanted to bring to the table, Scott. I was up really early this morning, 4 or 5 a.m., talked about excellence is not a destination. It's a continuous journey that never ends. So I thought that might be good to summarize what we're talking about today.
Yeah, I missed that quote. Sorry about that one, Russell. But yeah, I think, what you're talking about being a data-driven organization is something that's really important when you're talking about these customized metrics that you're looking for, and really how you're trying to manage on these metrics. But I think it leads to a little bit of frustration and some challenges and problems that we see in certain organizations where they're relying on what they can get just out of their billing system, or they're relying on payer data feeds or things like that to really get to what they need, and they're not exactly the way that they calculate them or want to track them, or they're not able to get to what they need to get to. And there's a number of reasons why that happens. They may be lacking resources from a staffing standpoint. They may lack the expertise to be able to get in and get the exact data that they need. It may not be, a huge budgetary priority within the organization as well. But really what it comes down to is a culture issue where, data is priority, a huge priority in these organizations, where we need to be able to get to what we need, especially if it's custom and it's something we have to go in and really work for to get.
Yeah. And so, we either talk about managing without the right metrics, or we talk about, sort of manually creating metrics month over month over month, where we might go into, the applications reporting, run a bunch of different reports, spend a lot of time crunching data in Excel, and then only to have to do it every time we want to refresh the data. So, it's very important to be able to have the metrics you need to manage effectively, whether we're doing it without them, trying to run our business without them, or trying to do it manually, but it's very time consuming. We spend more time getting the data rather than analyzing what's going on. So how do we tie these two concepts together? And really, let me ask a simple question of you, Scott, which is, how many patients did we see last year? And how does that relate to everything we've just spoken about?
Yeah, I think it relates perfectly, because when you ask how many patients did we see last year, 20 different organizations may give you 20 different answers, or they may ask a bunch of follow-up questions. Are we talking just unique patients? Are we talking all patients? Are we talking, all patient visits? Are we talking about visits that come from a scheduling system, or are we talking about some customized definition of visits?
Yeah, and I really love this. It's a existing patient in our population, but they're new again, right? Because we haven't seen them in 3 years, or whatever metric you might be using. So it creates challenges. Here's the question, but really, Scott, what's the right answer?
The right answer is actually very simple. It's whatever you need. Your organization, this is why we're talking about this today, is a customized thing, and you need to be able to get the KPIs that you need in order to manage how you were working on that. So it needs to be tailored for exactly the way that you're working on the initiatives that you have and what you're trying to drive for, because KPIs shouldn't just be numbers on a piece of paper. KPIs should be ways that we're steering the ship. And I found this quote while I was eating a banana split in the hotel the other night. The value of a KPI is it inspires action. Any KPI without action, it's just a number. So
I won't touch where the sprinkles on the banana split, the KPIs or something, but yeah. So let's talk a little bit about what are some of the unique patient KPIs that we've here at PDS been able to help organizations as part of what we do, helping them be successful with data and analytics.
Yeah. So, we talked about the patient counts. How do we get in? Are we talking unique patients where just the number of patients, one patient's only counted one time? Are we talking about patient visits where we see all of the patients that we've seen throughout a year, throughout a quarter? We can break out new and established patients. And then one thing that's becoming more and more common with value-based care contracts is allocation of primary care physicians. And how do we get that? We can find ways where some organizations want to say, the primary care physician is the one that the patient sees the most, or maybe the one that they saw last, or it may be the one that the patient registers with, but that patient could have changed insurances 3 or 4 times since the time that their insurance or information and their registration has been updated. Or we may be relying on payer data, and who the payer is telling us is an allocated patient for that provider. And so any one of these can be an important metric or gives you valuable information. It really depends on how you're using it and what you're tracking it for. When we talk about patient contact metrics, you hear a lot of times, oh, we want to look at visits, we want to look at encounters, we want to look at cases, things like that. And again, we've done a lot of different definitions for these for clients throughout the years. If you don't necessarily know where to start with some of these, you look at visits, you can get visits out of the scheduling system, but that doesn't take into account anything that's not necessarily scheduled that way. So the way we kind of look at it sometimes is we look at a patient, provider, or providers and data service, and that constitutes a visit that goes forward that way. Whereas you may have an encounter that's a little bit different, where maybe you have a patient who sees a couple of providers during the day, and on that same data service, and that would incorporate 2 encounters where that would only be 1 visit, that sort of thing. Cases is something that a lot of surgical practices are interested in, where it's still the same 1 patient, 1 provider, but it's only certain CPT codes that we're tracking, and we want to look at it that way from a case standpoint. Or again, value-based care is starting to look at episodes of care. And so we can track, 1 patient, 1 provider, but over many different dates of service, and we're looking at key diagnosis codes for that. We're kind of grouping everything based upon that diagnosis code to get what we consider to be an episode of care. Now, you may have different definitions that you want to do, but this is kind of a good starting point if you're looking to move in that direction.
Yeah, a lot of unique ways to count things. Certainly, we talked a little bit about this in part 4 of our webinar series, but with value-based care, the challenge with the payer allocated PCP versus, who we have registered, the patient registered PCP, just trying to reconcile some of those things, which may or may not line up when you just sort of pulling canned reports. But, the key here is, we're not just talking about metrics, but the value of automating customized KPIs, right? So why do we want to automate them, to use that term, and focus in on them? So we talked a little about this in part 4 of our data modeling webinar, which was just 2 weeks ago, where if the data has been structured appropriately, it's built down at the detailed level and rolled up into your customized KPIs. And what that allows you to do then is the users are not limited to just working with it in a report or a dashboard. They can work with it in a visualization. We'll talk more about visual tools coming up here. But they can also then move between the visualization, the detailed reporting, and those data cubes, which gives them that slice and dice capability. So by automating your KPIs and staging them appropriately from the detail up, the users really have all the pieces of data that they need. And as I mentioned, we discussed this in part 4 of our webinar series, which really goes back to why modeling data appropriately means you can then empower the users with the right tools. But before we showcase that a little bit more, Scott, let's talk about RVUs for a second, because we're going to talk about patients and then we're going to talk about visits. To me, the next logical place to go is, what about RVUs?
Yeah, it's interesting because you think RVUs, customization, an RVU is an RVU is an RVU. And the fact of the matter is that's simply not true. We've done a lot of different calculations for clients over the years based upon the way that they need to track and report on RVUs. A lot of times, really, you just need the annually updated CMS RVRVS table, and that will do for their RVU calculations. They may want some modifier adjustments that come into play, but sometimes people want different modifier adjustments based upon the way different payers contract to do their reimbursement adjustments on modifier adjustments that way. So we've had to do some customizations there. A big place where we do it is incorporating unlisted codes or pseudocodes, particularly with practices that have high OB or pediatric services that they're providing there, where those different services aren't necessarily tracked by the RBRVS table that comes from CMS. Some people have different compensation RVUs so that they're calculating on a more standard basis that way than they are for their productivity benchmarking. Or sometimes what they've wanted us to do is to calculate multiple years of RVUs because of some significant changes that have come across from CMS, for example, when in 2021, when they made the big adjustments to the RVU calculations for the E&M codes. People wanted to look at what it was before and what it was after so that they could track what are the differences in physician productivity that are attributed just to the changes versus to just any additional work that the provider was doing. So really, there are a lot of customizations that can happen just on a single metric like an RVU.
Scott, I see a quote that just popped up here, and I thought it was a quote maybe that you'd pulled out, but as I remember correctly, this is a quote I pulled out, and I'm going to quote you here and say, we always say there's nothing we haven't done to an RVU, but every time I talk to a new client, they surprise me. I've heard you say that many, many times.
I do say that, and I anticipate getting surprised many more times. So,
yeah. So let's go ahead and see if we can't tie some of these, what I consider fairly simple metrics. We've talked about patients, we've talked about visits, we've talked about panels. So here's a web-based visualization where we can point and click, we can drag and drop, we can filter through the different data points. And so we're looking at some fairly simple things like panel size by payer, patient count by gender, patient count by payer, and start to understand what's going on in our data. So, having those metrics calculated the way we want to see them means we can slice and dice through the data. We can make changes. It's interactive. Let's go a little further though. And now let's talk about looking at things like productivity. We're looking at, say, RVUs. We might have our custom visits definitions, procedures, even breakout of things like testing, radiology. And so again, our dashboard is fully visual, it's interactive, we can point and click, we can drag and drop. The big thing here, though, that we've talked about by having these customized RVUs, our metrics, our procedures, our categories, is we can move from visual dashboard into data cube or OLAP analysis, I like to call it, which is that analytical processing. It allows me to continue to slice and dice through the data. And on purpose, we've moved from a web-based visualization into something that looks more like a pivot table or a chart. Can continue to slice and dice through the data. I can add dimensions that maybe weren't in my initial report, like location category or payer, et cetera. And from here, I can continue to do analysis. And if I want to, though, I can just point and click and drill right down into the details. So now we're moving from visual to cube down to the patient level transactional detail as if we're writing a report. And so you can see now on the screen here, I've got patient level detail, but I can also continue to slice and dice and filter through the data and continue to work with whatever the metrics are, whatever the detail is, whatever was designed. So I have those custom KPIs, but I really have all of the supporting detail behind it. So it makes it very easy to work with data, very easy for the users, because what we've done is we've made it so we can move between different levels of the data.
Important when you talk about, how difficult it can be, particularly with customized metrics, and everything is calculated a little differently if you have to move from one piece to the other by having to recreate queries or functions and things like that to have to do that.
Yeah, so a lot of organizations, visualization tools, they're very popular. People using Power BI, Tableau, Click, for the visualization piece, and the visualization tools are kind of what I call the fun part. The challenge, though, is if you're then creating a picture or a static PDF or something like that, and the user needs to go beyond what's been built, you've either got to go to another tool, maybe Excel cubes or pivot tables, or you've got to write queries, try to pull that data out and then re-summarize it, all trying to get to the answer. Where if you've staged your data appropriately, you've created your customized metrics, right? You can slice and dice. The users have what they need. They have it the way they need it. And it makes it much easier. And that's really how being data-driven, that sort of best practice allows you to do that. And so talking about levels of data, let's talk a little bit about how sometimes the categories that users need for reporting can create customizations and custom KPIs.
Yeah, it's not just, practice level customizations that are out there sometimes. Sometimes, there's customized reporting categories or hierarchies that need to be created within the organization itself. So for example, different managers may need different information staged a little bit different way in order to track initiatives that they're leading. If you're a large organization that spans multiple states, there may be different reporting requirements or things that need to be done by state level or region level, things like that. If you start looking at different providers, employed providers, contract providers, things like that. A big one that people are looking at now as costs are coming more into play with value-based contracts is tracking by cost center. And that can be something that's a little tricky, where you may have a billing system and a GL system that don't necessarily talk to each other very well, but you want to be able to report at those levels and integrate those data together.
So let's go ahead and take a look at a visualization where we've actually done that kind of work for organizations, which is the ability to report out of your general ledger and the ability to be able to change perspectives and slice and dice through data, right? So just being able to do costs and cost centers oftentimes requires some unique calculations. But whether we're doing kind of summary, understanding benefits, revenue, expenses, and budget data, or we really want to get all the way down into, just being able to sort of automate and make it easy for users to see how our expense data rolls up into different buckets, categories by specialty, really can be tremendously time savings, especially if you're a growing organization.
Yeah, and I think one of the things that you look at this way is you may not have necessarily the same levels of hierarchies in your GL as you do in your billing system, or whatever levels you want to report at from a productivity standpoint. But maybe you want to create a dashboard at a provider level, and you want to start looking at contribution margin, where you're incorporating expenses, but those expenses may not necessarily be tracked at a provider level. What you may need to be able to do is try to allocate those expenses at a certain level or another. One of the ways we recommend that is by tracking expense per RVU, and looking at it from that standpoint. And what that'll allow you to do is to take the RVUs that are attributed to a certain provider and calculate an expense per RVU, and that way you can start tracking provider level contribution margins or clinic level contribution margins that may not necessarily be available directly out of the general ledger. I think one of the things that we talk about this, and this is something that I came up with while I was waiting in line for the Haunted Mansion at Disneyland. The key performance indicators are really your dashboard. It's not just putting the paper together. We want to choose what we're tracking wisely, and we want to get down to certain levels of granularity so that we can specifically see what's working and what's not working.
Yeah, so I can't speak to your satisfaction at Disney, but I can certainly speak to patient satisfaction data, and obviously, how important that is. We've talked about this in several parts of this data-driven series, but it's not enough to just look at productivity, but really understanding how are the patients feeling about our productivity. So, the patient survey data, being able to roll that data up together. We've talked about that in the various aspects of data modeling, but what we really may want to be able to do is to be able to categorize that data quickly, whether it's directly using the categories coming from servers, or maybe it's some of our own internal trying to categorize the various questions and survey questions so we can better understand where we may potentially have problems or challenges. So again, leveraging sort of custom categories, custom rollups with our data, ultimately trying to drive and shed light on where we have performance opportunities.
Yeah, and I noticed one of the things that you have in here is, patient access, and that can be a huge driver of patient satisfaction when you get there. And that's when you want to start breaking things down and trying to understand, is it that we simply lack capacity, or do we have problems maybe in an area like our call center?
Yeah, and certainly call center data obviously, again, presents some challenges. I one time sat in a meeting with an executive who said, well, I want all my call center data to roll to the department or specialty that it applies to. And right away there was this, but we don't have a one-for-one between every specialty in our organization and the way our call switch works. And so that alone created some challenges as to how they were going to allocate and how we were going to model the metrics to say, were these abandoned calls or these long wait times coming from specialty care versus, say, primary care? So even that created challenges that had to be somehow discussed, a business definition created before we could even think about what's the right way to do that as a metric.
Yeah, well, and if you want to add another variable to the whole mix as well, if you're starting to look at, long patient wait times or hold times or abandoned calls, a lot of that could directly go back into staffing. And so I notice a lot of organizations these days, particularly in the staffing level environments that we're in right now, are really placing a lot of emphasis on tracking employee turnover, looking at, are we adequately staffed? Can we keep staff? Are we losing staff? And it's not even just making sure that we have adequate staffing levels, but there's a huge cost involved in employee turnover these days with retention bonuses versus new hire bonuses versus recruitment costs. And so all of these things really come into play as things to track as well for coming up to one personal level on patient satisfaction. So there may be a lot of variables that we're trying to track just to get to one single answer that's out there.
Yeah, and so Scott, what you're talking about is something, again, we've covered in these previous webinars. I'm not going to get too deep into it, but it's that ability to blend data, right? So we're blending things like call center with patient access, with patient survey metrics. And we've talked quite a bit about that in the previous areas. Ultimately, though, by being able to blend data, calculate those custom KPIs, right? It's about being able to ensure that the users have the information they need at their fingertips so they can manage effectively. And that's, a big part of being data driven. And so I found this quote while I was walking from the car into the office this morning, and it talks about how KPIs are less about measuring and more about communicating strategic objectives, aligning behaviors, and providing a feedback loop for continuous improvement, which is really what I think we're trying to do here with these custom metrics, right? Continuous improvement.
Yeah, no, that's definitely true. And when we get into it and we start looking, organizationally speaking, I think the biggest differentiator where we're looking at customized metrics is where we're talking about different reporting for different specialties, where what one specialty reports on or is a big priority may be very different from a second specialty that you're looking at. And there are a lot of different considerations when you're looking at customizations. There are quality measures. Which PQRI measures are you reporting on? Or do you have subspecialties that you need to track, or modalities or things like that? A lot of specialties now have cosmetic or elective and clinical services that they're tracking a little bit separately, or retail and pharmaceutical things that they're looking at. And so all of these things really come into play. And again, every specialty is going to be a little bit different. The biggest one that I'm seeing out there is the marketing for different specialties is very, very different from what they're looking at. And so you want to find out what's effective in your marketing. And in order to do that, you have to have some very customized data that you're tracking to get there.
Yeah, without a doubt, and we're certainly seeing that a lot of specialties spending more money on marketing as the healthcare industry continues to consolidate, and differentiation is key. We're going to touch on a bunch of specialties here at a very high level. I'll say that we could do a webinar on any single specialty. That's not our goal today, but certainly if you're interested, or if you are a specialty group, we can certainly provide more information and share a little more than we have time to get into today. But, OBGYN, one area, whether we want to break out the OB work from the GYN, we want to look at visits, visit types, screening tests, many of the things, Scott, that you touched on right on the left side of the screen here really apply. Certainly, just a number of metrics, including, things like call coverage, and who's on weekends or nights that's covering for the deliveries.
Yeah, and that's going to be different than what we would report on for like a radiology practice, where we may want to look at productivity by modalities and things that we're looking at that way. Or a big one that I'm starting to see right now in radiology a lot is tracking charge lags, because cash flow can really be optimized in a practice like radiology, and it's something that hasn't typically been emphasized before.
Yeah. And going to some of your more what I consider, primary medicine type specialties, cardiology in particular, certainly we may want to look just at, testing or equipment costs, running all those, EKGs, et cetera, time, staff time. But any of those metrics that might be sort of sub to just the clinical services provided can be key, especially if you're looking at areas where either, there might be questionable profitability, or maybe it's time to renew or some equipment.
Yeah, so one of the ones that we've been working with a lot recently is dermatology, and there's been kind of a shift in dermatology practices now, where more and more you're seeing dermatology have their core clinical business that they're working with, but they're also taking on kind of a retail component that goes along with it, and a cosmetic component that goes along with it. And so one of the things that we see people doing is starting to look at, maybe looking at these a little bit differently, where from the clinical side, they want to look at the overall visits and number of patients and diagnoses that they're treating that way. But then they may want to have another dashboard where they're tracking kind of their retail component, their cosmetics, their laser procedures, and the retail products and skincare products that they're selling right there within the clinic as well.
Yeah, and even going a little further to understanding who's doing a good job with that, which physicians or care teams are encouraging patients on some of the products versus others. There might be some performance gaps there that could be identified. Going a little further, certainly, again, we could look at something like orthopedics, and then, of course, all of the ancillaries that orthopedics have, from radiological equipment to, PT, and having a whole set of metrics on physical therapy, what's, internal recommendations versus external recommendations to the PT, or, even the DME, what are we providing, where are we buying them, what's the turn on, equipment that we might have, on the back shelf, things like that. So just so many different areas that we could dig into when we think about orthopedics.
Yeah, and then you move on to something like ophthalmology, which I kind of look at as a hybrid between the two, where you have that heavy surgical component that's still sitting there, and you want to track the different procedures that you're doing and the physician productivity related to things like that. But you also have that retail component that exists with your eyewear and your contacts, as well as maybe more elective procedures like LASIK that you're working on, and even different ophthalmology practices are going to have different emphases, where I see some that are really just a LASIK practice that works that way. And so again, those marketing is going to be very, very different, and you want to track what's being effective with your marketing that way. So
yeah, a lot of similarities: ophthalmology, dermatology, anybody who's doing elective versus cosmetic type procedures, certainly. Looking over at something like nephrology, where we may want to be very focused on, how many transplant patients, or how many patients are waiting for transplants, how many transplant patients are now under our care. Also looking at things like our dialysis clinics and the staffing and even location costs. So just a number of different custom metrics that come out of different specialties.
Yeah, and another one we've started working on a lot more as well, which is a very different practice, is allergy, where allergy relies a lot on testing. It relies a lot on, are we able to convert them over to long-term immunotherapy? Are we being able to retain patients? Are we able to attract new patients? And we want to be able to have reasonable access to all of these services that we've had. So those are kind of the key priorities that our allergy clients have been looking at, and that's really kind of very different from all of the others that we've reported. So I think you can see how the specialty level reporting can really take on a life of its own. And that's where you really need these customizations, that you can't just say 1, 2, 3, these are the 5 things you should be reporting on. Everybody's going to be a little bit different.
Yeah, without a doubt, Scott. And so, we've been talking about custom KPIs, specialty KPIs. We talked a little bit about different relationships, both in the specialties and otherwise. But, the last area being data-driven, the highest level of what we call analytical intensity, is this ability to project improvements, project outcomes.
Yeah, and I found this quote sitting on the top of the Ferris wheel there, that KPIs are not just about assessing past performance, but also how to steer your organization towards a future outcome. We're not just seeing what happened. We want to improve what is happening, and we want to be able to take steps in order to drive it to where we really want to get to.
So just to highlight sort of quickly here, we talked in part 1 of our webinar series about scheduling metrics, patient access metrics, looking at things like, wait time in the waiting room, wait time in the exam room, time spent with the physician, comparing the physician's time allocated for a patient visit with the actual time being spent. So a whole variety of custom metrics come out of patient access, and you can catch that in part 1 of our webinar series. Part 3,
we also talked a lot about Medicare utilization rates, or wellness utilization rates by provider, and how the financial opportunity that comes from that, whether you're on value-based care contracts or not. We talked about that in part 3 of our webinar series, if you want to go back and look at that. But there's a financial component that can help you kind of drive change in order to effectively better manage your patients with chronic conditions as well.
Yeah, and I would challenge, Scott, the whole calculating HCCs, especially with what's coming in 2024, is highly custom because of the way they're blending the risk scores and the changes of risk scores based on year-over-year scores. And we'll be talking more about that coming up in January. We're going to have a webcast on that coming up as well. So, the value of having customized KPIs is the ability to leverage them, to report on them, to be able to sort of just click and drill through and really understand how is your organization performing and where is it performing. And the last thing that we wanted to talk about today, given where we are with the time, I'm going to push you off and say, please come to part 6, but we're going to be talking about physician compensation. And to me, physician compensation reporting and analytics is really about being able to deliver customized KPIs that then you can measure to what is the calculated physician's comp and earned physician's comp. And so we're going to be talking in part 6 about the variety of different plans that could be from RVU-based plans to collection-based revenue to the new value-based care plan. So we'll be talking more in depth on that topic, but I would challenge as we think about customized KPIs, how many of those custom KPIs are part of your comp plans, and then how to best model comp plans. So Scott, a few last words here.
Yeah, so to continue our little quote off that we've been having in this one, I've had a lot of free time on my hands, so I got a few others that I want to throw out there that really kind of sum up what we've been trying to say and just talk about, first of all, it definitely is a delicate balance between precision and relevance. Make sure you're measuring what's important to you, but be precise when you do it.
And Scott, I would come back with the goal is to turn data into information and information into insight.
Yeah, no, that's definitely critical as well. This is one that I thought was great when we're talking about what are going to be the key initiatives where, someone said, in God we trust and all others must bring data.
Yeah, that's a good one. It's hard to compete with that one. How about just what gets measured gets improved, right? Well, Peter Drucker.
Yeah, no, that's good. But I think, what really sums it up the best is going back to Galileo. Let's measure what's measurable. Find out what's important. Let's measure it. And if it's something that's important that we don't necessarily know how to measure, or we don't think it is measurable, let's figure out a way to make it measurable, because we really have to track these things. It's not going to improve by itself. We need to make sure that we're taking the correct steps, and we can't do that if we're not accurately tracking the best data that we can.
And Scott, I found that exact same quote thanks to the AI that I was using. So, but well said, I think. So with that, I guess we could just wrap up. Certainly encourage you, if you're struggling with metrics, you're needing help, you can't automate or model, we'd love to certainly speak with you. This is what we do here at PDS. We do it every single day, helping organizations be successful with data, and hopefully we've shared some insights. Also, if you're a specialty practice and you'd like to learn more about metrics or things that we could help you do to your particular specialty, we'd also love to hear from you as well. So with that, thank you so much for joining us, and hope you have a wonderful, wonderful day.
All right. Thanks, everyone.